Hello everyone, this is Dr. Gobind Rai Garg. In this video, we will discuss the recall questions which were asked in FMGE July 2024. Starting with the first question. A 55-year-old male patient with a history of hyperlipidemia was started on statins. He was started on statins. Despite the statin therapy, triglyceride remain high over 600. So which drug should be given? So basically, hypertriglyceridemia, if it is too high, it increases the risk of pancreatitis. So we do not want pancreatitis. So we want to decrease the risk of pancreatitis. We want to decrease triglyceride level. The first choice, if triglycerides are not too high, are statins because they will control cholesterol also. But the second important choice will be fibrates. Fibrates are specific drugs to decrease triglyceride level. So the answer to this will be gemfibrozil. So quickly discussing, ezetimibe, it inhibits the intestinal absorption of cholesterol. Niacin is vitamin B3. Its major function is to increase HDL cholesterol. It is maximum HDL increasing drug. Gemfibrozil are fibrates. They act by stimulating PPAR alpha, and these have maximum triglyceride lowering potential. Evolocumab is a new drug. It is PCSK9 inhibitor indicated in homozygous hypercholesterolemia. The answer to this question is gemfibrozil. Moving to second question. 52-year-old male presents with headache, confusion, visual disturbances, nausea, vomiting and seizures. On examination, blood pressure is very high. What is the treatment? So basically, it is a case of hypertensive emergency with encephalopathy. Features are of encephalopathy. So the drug of choice for hypertensive emergencies in different situations, if we see in patients with seizures, or we can say encephalopathy, the drug of choice is nicardipine or labitalo. These are drug of choice in hypertensive emergencies with encephalopathy. Similarly, if there is patient with intracranial hemorrhage, the same drugs are drug of choice. For intracranial hemorrhage also, this is a drug of choice. But in a patient with acute coronary syndrome, if there is acute coronary syndrome, we prefer intravenous nitroglycerin. On the other hand, in a patient with, we can say pulmonary edema, the preferred drug will be intravenous nitroglycerin again, but we can also use sodium nitroprusside. Nitroprusside can also be used. Then in a patient with aortic aneurysm or aortic dissection is better way to say, aortic dissection, the drug of choice is again nicardipine, but it is always given in combination with a beta blocker like esmolol or even labitalo. And lastly, in a patient with pregnancy, hypertensive emergency in pregnancy, the drug of choice is labitalo. So these are the drug of choice for different type of hypertensive emergencies. So if you see which is the most appropriate, oral nifedipine, obviously it is an emergency, so oral drugs will not work. Nitroglycerin is usually avoided in a patient with CNS problem, like in case of encephalopathy or intracranial hemorrhage. So the drug of choice here will be IV labitalo. Okay. Moving to next question. A 45-year-old male was on metronidazole therapy for bacterial infection. He attended a party and consumed alcohol. Shortly after, he developed symptoms including facial flushing, nausea, vomiting, headache, dizziness, palpitation, hypotension. So everyone knows this is a disulfiram-like reaction. Disulfiram-like reaction. The meaning is normally alcohol is metabolized to aldehyde and aldehyde is metabolized to acid. The first enzyme is alcohol dehydrogenase. Second enzyme is aldehyde dehydrogenase. Now disulfiram and many other drugs like metronidazole, they inhibit aldehyde dehydrogenase. So if a person has taken metronidazole, aldehyde dehydrogenase is not working, so aldehyde will accumulate, and it is this aldehyde accumulation which result in these symptoms: nausea, vomiting, headache, palpitation, hypotension. So this is known as disulfiram like reaction. So it is basically a drug interaction between metronidazole and alcohol. It is not a symptom of metronidazole overdose. It is not methanol poisoning. Methanol poisoning person may develop ataxia, severe sedation, these symptoms, and alcohol withdrawal. There is no history of withdrawal given, so we cannot come about withdrawal. Clear? So answer is the drug interaction. Moving to next question. Which of the following drug has dual activity against hepatitis B and HIV? This we have discussed several times. So there are some drugs which are used in hepatitis HIV, and they say now let us treat hepatitis B also. So the drugs having dual activity are remembered as letter drugs. So letter drugs are lamivudine, emtricitabine, and tenofovir. So among these, the option contains tenofovir. So tenofovir is the answer, having dual activity against HIV as well as hepatitis B. Next question. A man with diabetes was on medication and forgot to take meals before going to gym. During his workout, he collapsed and blood sugar was found to be 50. So that means the person is developing hypoglycemia. The question is, which oral anti-diabetic drug can result in hypoglycemia when used as monotherapy? So we discussed our mnemonic: any drug whose name end with "ide", any anti-diabetic drug whose name end with "ide" can cause hypoglycemia. Except the only ides which do not cause are glutides. So like liraglutide. So this group of drugs, liraglutide, exenatide, although that is not glutide, so that group of drug do not cause. Any other drug which end with ide will cause hypoglycemia. So among the given options, glimepiride is ending with ide, so that is the answer. Other drugs do not cause hypoglycemia. So glimepiride is a sulfonylurea, it can cause hypoglycemia. Okay. The next question, which anti-cancer drug can result in hand and foot syndrome? This is just a rectification question. So two drugs, 5-fluorouracil and its prodrug capecitabine. These are associated with hand and foot syndrome. Capecitabine and 5-fluorouracil. They can cause hand and foot syndrome. So the answer here is capecitabine. Cyclophosphamide, the main side effect you need to remember is hemorrhagic cystitis, and it can be prevented by mesna. Bleomycin, two side effects you need to remember: one, pulmonary fibrosis, and second, it can result in flagellated pigmentation of skin. And paclitaxel can cause peripheral neuropathy. So the answer to this is capecitabine. Next question, a 60-year-old female on anti-diabetic therapy for last 10 years. She experienced 3 episodes of vaginal candidiasis in last 2 months. So she is prone to develop the infections. So which anti-diabetic drug should be avoided? So basically urogenital infection risk is caused by which group of drugs? Yes, it is caused by SGLT2 inhibitors. So remember, SGLT2 inhibitors inhibit the reabsorption of glucose. So they act by causing glucoseuria. So when more glucose is in the urogenital tract, it increases the risk of UTIs. So we will avoid these drugs, and the name of these drugs end with gliflozin. Like canagliflozin, dapagliflozin, empagliflozin. So gliflozin, you can remember, if we write urine at the end, the mnemonic says that glucose flows in urine. So they act by causing glucoseuria, and the drug is canagliflozin. Okay. Which is the preferred drug for total intravenous anesthesia? Remember, for total intravenous anesthesia and for day care surgery, the drug of choice is propofol. Propofol is the drug of choice for total IV anesthesia and day care surgery. Ketamine, it is producing dissociative anesthesia mainly. Ketamine produce dissociative anesthesia. Etomidate, it is safe in cardiovascular surgeries, particularly do not affect the cardiovascular system. So aneurysm surgery like drugs, inducing agent will be etomidate. Okay, so answer to this question is propofol. Next question, which drug work as NMDA antagonist? So we have already discussed the mnemonic of ketamine. Remember, ketamine I have taught you many times. So K for kids, preferred in anesthetic agent in children. E for emergence reaction. So there will be CNS side effects while recovery. T for thalamocortical junction, which is responsible for dissociative anesthesia. A is analgesic. It is the most powerful analgesic drug among all the anesthetic agents. M is meals, can be given in full stomach. I is increase BP, intraocular pressure and intracranial pressure. And N is NMDA antagonist. So that is the mechanism of ketamine which is asked in this question. Which is NMDA antagonist? Answer is ketamine. And E is excellent bronchodilator. It is a powerful bronchodilator. Now, which drugs are NMDA antagonist? So you can remember the important NMDA antagonist as kill NMDA receptors. So these kill NMDA receptors. So what are NMDA receptor antagonists? K for ketamine and its brother S-ketamine. N for nitrous oxide. M for memantine. D for dextromethorphan. A for amantadine. And R for riluzole. So these are the important NMDA receptor antagonists: ketamine, nitrous oxide, memantine, dextromethorphan, amantadine and riluzole. So answer to this question is ketamine. Moving to next question. A patient is undergoing treatment for cancer with methotrexate. What is the mechanism of action? We all know methotrexate is dihydrofolic acid reductase inhibitor. So folic acid is produced from pyridine plus PABA plus glutamine. These three together form folic acid, which is dihydrofolic acid. And this dihydro is converted to tetrahydro by dihydrofolic acid reductase enzyme. This tetrahydrofolic acid is required for DNA formation. So methotrexate inhibit this enzyme. So by inhibiting this enzyme, there will be less production of tetrahydrofolic acid, means folic acid cannot be activated. So DNA will not be produced. Okay? So it is an anti-metabolite which inhibits dihydrofolic acid reductase. Next question. A 58-year-old hypertensive patient with history of MI developed acute attack of migraine. Which drug should not be given? Remember the main drug which we use in migraine like sumatriptan or any triptan, plus another drug which we commonly use in migraine is ergotamine. Both of them, they act by stimulating 5-HT1B1D receptors. Now this receptor stimulation result in vasoconstriction. Now if this vasoconstriction occur in the brain, it is required, it will treat migraine. So that is the mechanism in migraine, acute attack of migraine. But they can cause vasoconstriction outside the brain also. They can cause vasoconstriction in periphery as well as vasoconstriction of coronary artery. So by causing vasoconstriction in the peripheral vessels, they can result in gangrene. Ergotamine has more chance than sumatriptan. And second, they cause coronary artery spasm, so they can worsen patients of myocardial infarction. So these both drugs are avoided in patient with MI. Right? So the answer to this question is sumatriptan. So ibuprofen is commonly used as drug. Propranolol, verapamil can be used safely. Okay. Next question. A log DRC was plotted with isoprenaline alone and with isoprenaline in presence of propranolol. So what it shows? First of all, we'll see the log DRC. If we use only isoprenaline is this, then if we keep on increasing the dose of propranolol, the graph keep on shifting toward right. So it is a parallel shift to the right, and parallel shift to the right tells that it is a competitive antagonist. So propranolol is a competitive antagonist of isoprenaline. And if we know that isoprenaline work on beta receptors, so it is a competitive antagonist of beta 1 receptors. Okay. Next is the question, mechanism of rivaroxaban. The name itself says XA, that means it is a 10A ban. XA will be banned, so that means it is a 10A blocker or inhibitor. So answer to this is 10A inhibitor. So it is a reversible oral 10A blocker. It is used as an anticoagulant. It is a new oral anticoagulant. So any drug ending with hexaban is a 10A blocker. Other drugs in this group are apixaban, edoxaban and betrixaban. So any drug which is hexaban is 10A blocker. A 25-year-old patient diagnosed with absence seizures is being treated with ethosuximide. What is the mechanism? Now, absence seizure occur due to overactivity of T-type calcium channels. So, if any drug inhibit T-type calcium channel, it can be used in absence seizures, and that is done by ethosuximide. So, ethosuximide is a T-type calcium channel blocker. Remember, sodium channel is inhibited by many drugs including phenytoin, carbamazepine, even valproate, lamotrigine. So many drugs act by inhibiting sodium channels. GABA transaminase inhibitor is vigabatrin. Vigabatrin is a GABA transaminase inhibitor. Whereas arabinoyl galactase, this is inhibited by ethambutol. It is used in tuberculosis. So do not confuse ethambutol with ethosuximide. Okay. So the answer is inhibit T-type calcium channels. A 22-year-old female seeks advice on effective post-coital pill. So, emergency contraceptive which is most suitable. So, we all discussed several times that emergency contraceptives, they can be used within 72 hours of unprotected intercourse. They include combined oral contraceptive, combination of ethinyl estradiol with levonorgestrel, or we can use only levonorgestrel, or we can use mifepristone. So all three should be used within 72 hours. Then second drug which we can use up to 120 hours after unprotected intercourse, it is ulipristal. Ulipristal. Okay. So among the options, the best answer is levonorgestrel. Okay. Next question, a 45-year-old patient has just undergone surgery and requires a drug to reverse the muscle relaxation. So basically here they are wanting to ask about reversal agent. Now reversal agents are of two types. One which is commonly used is neostigmine. Neostigmine is commonly given with atropine. And second drug is sugamadex. Sugamadex. Now, neostigmine-like drugs, they act by inhibiting acetylcholine esterase. So, that will increase acetylcholine. So, it produces cholinergic side effects. Cholinergic side effects can occur. That's why we add atropine to stop those side effects. On the other hand, sugamadex is known as selective relaxant binding agent. It is particularly indicated to reverse the action of rocuronium and vicuronium. SRBA, the important thing is it is fastest acting reversal agent. Fastest acting reversal agent, and they do not cause cholinergic side effects. They do not cause cholinergic side effects, so atropine is not required. So in this question, the option will be neostigmine, which is the answer. Okay. A 30-year-old pregnant female is advised to take folic acid supplement. Why? This is the basic most question. The answer is to prevent neural tube defects. So folic acid dose normally in pregnancy is 400 microgram per day. But if the female is taking anti-epileptic drug or it is at risk of neural tube defects, then the dose of folic acid is 4000 microgram per day. So it is used to prevent neural tube defects. Next question, a 40-year-old patient undergoing treatment for tuberculosis reports experiencing decrease in visual acuity and color blindness. Which drug causes? It's very easy question. So E for ethambutol, E for eye problems. Ethambutol affect the eye. So what it does, it cause optic neuritis, which present as decrease in visual acuity as well as color blindness. particularly red-green color blindness. Okay. Now, isoniazid is mainly causing liver damage, hepatotoxicity, and it can cause peripheral neuropathy due to deficiency of vitamin B6. Rifampicin cause orange-colored urine, and rifampicin is a powerful enzyme inducer. So, lot of drug interactions. Ethambutol, we discussed E for eye problems, and pyrazinamide is hepatotoxic, and it also causes several hyperuricemia causing problems. Hyperuricemia. So, among these, the answer is C, ethambutol. Next question. A 35-year-old male present to emergency with high fever, severe headache, confusion, and altered consciousness. History of travel to malaria endemic area. Signs include jaundice, anemia, and dehydration, weak pulse, thrombocytopenia. So basically the symptoms of severe malaria is there, and it is confirmed because there is presence of Plasmodium falciparum. And we know the drug of choice for severe malaria is, yes, it is intravenous artesunate. Intravenous artesunate is a drug of choice for severe malaria. So this should be continued minimum 24 to 48 hours. IV therapy. After that, whenever the person can take orally, shift the person to ACT, artemisinin based combination therapy. Clear? So chloroquine is not usually effective in severe malaria or falciparum malaria. IV artesunate is the answer. ACT is used after saving the patient. Remember, ACT is oral therapy. After saving the patient with intravenous artesunate, we will start ACT, and primaquine is for radical cure of bivax malaria, not for falciparum. So answer is intravenous artesunate. Moving to last question. A 50-year-old male present with bronchial asthma is on ipratropy and a formoterol inhaler. Despite medication, symptoms are not improving. Why? Because there is incoordination of hand and inhaler use. Remember, whenever person has to inhale, it should be coordinating with inspiration. The person is not able to do. So what should be the next step? If the person is not able to use inhaler properly, the next thing is we will use nebulizer. Remember, nebulizer is a machine from which the mist comes on the nose and it can be inhaled. So better answer will be to use nebulizer. Monitoring the plasma level is usually not done. Dry powder inhaler, whether it is dry powder or it is mist inhaler, the answer will be, problem will be same. That means coordination is required. Budesonide can be added, yes, but problem is it will not solve the problem of coordination. So we have to use a nebulizer. Okay. So these are the important questions that were asked in FMGE exam. Thank you very much.